Thank you for attending this Election 2012 Roundup, the Future of Healthcare Reform webinar. We here at UCAN, Ohio are breathing a sigh of relief because we know the Affordable Care Act is here to stay. But here in Ohio, our celebration hasn't lasted long. Our priorities have shifted from advocating to protect the law to ensuring that implementation works for all Ohioans. Today, we're joined by Michael Miller, Policy Director at Community Catalyst. He will be discussing the looming federal fiscal cliff and what it means for healthcare reform. We will then open it up for 1 to 2 questions relating specifically to the fiscal cliff. Then we will move on to presentations by Kathleen Geminer, Project Director of Ohio Consumers for Health Coverage on insurance market reform. Then Kathy Levine, Executive Director of UCAN Ohio on the Medicaid Expansion. Then Nita Carter, UCAN Ohio's Health Equity Project Director on Communities of Color. And finally, Kathy Levine will wrap up with Ohio's efforts to control spending by delivering better care. We will then open it up for questions. Throughout the presentation, please submit your questions using the question box on the right-hand side of the page. Please submit your questions pertaining to the fiscal cliff first, and those will be the first questions we will be answering. Without further ado, here is Michael Miller, Policy Director at Community Catalyst.
Hi, thanks so much. Very happy to be here and glad that we are where we are with respect to the election. Obviously, from a healthcare point of view, it's a lot better than the alternative. So what I'm going to do is briefly talk about the so-called fiscal cliff and where it came from and what it means for healthcare reform. I have to say it's another classic example of bad branding by progressives to accept the name fiscal cliff because it seems like something that we would want to avoid at all costs. But I got to say that as challenging as it may be, as concerning as it may be, there are worse things, and I will talk a little bit about those briefly. So first off, what is the fiscal cliff really? It's really a series of fiscal events that will occur either at the end of this year or early next year that could trigger another recession. And that's the reason for the concern, is the impact that some of these things would have on the economy. And critically, there are 3 elements to it, although often people only talk about 2. But the 3 are the expiration of tax cuts that are often referred to as the Bush tax cuts, as well as tax cuts that were passed during the Recovery Act under President Obama. The imposition of something that's called the sequester, which is across-the-board spending cuts in both domestic and military spending, and the need to raise the debt ceiling. So I just want to make a couple of points here about the fiscal cliff. And the first is that, at least as it relates to the first 2 elements, the problem, people always get this mixed up with, don't we have this big problem with the debt? And the problem with the fiscal cliff is it actually does too much too soon to reduce the deficit, as opposed to not addressing the debt problem. So basically, the idea is that austerity, which is sort of reducing demand in the economy, is a dumb idea when the economy is still operating below capacity. And so the question is, why are we grappling with this dumb idea? And that brings me to the debt ceiling, because it was the debt ceiling debate last year that gave birth to the super committee, people may remember, and it was the failure of the super committee to agree to a mid-range deal on debt reduction that led to sequester. Sorry, having a little distraction here. Okay, that's better. And the reason that no deal was reached by the super committee was basically the refusal of Republicans to agree to revenue as part of the solution and the demands for deep cuts in Medicare and Medicaid and in Social Security. So where we are now is that President Obama has said he will not extend the tax cuts, the Bush tax cuts for top earners, and Republicans refuse to extend cuts for the middle class unless the rich get them as well. And so I think that if I had to put my money down on InTrade or one of the other political betting sites, my bet would be that it's over the cliff for us. But again, it's a misnomer because it's not like anything horrible happens right away. And we will have time to fix it and impetus to fix it. So let me pivot here to what matters for healthcare. So the first thing is, as I said at the outset, that the sequester is a bad thing for the economy, but from a healthcare point of view, things could be much worse. Medicaid is entirely exempt from cuts in the sequester. All Medicare benefits are protected. Medicare rate cuts are limited to 2%, where other programs are looking at something in the ballpark of 7% cuts. Tax credits on the Affordable Care Act are entirely protected, and all domestic spending cuts are balanced with a roughly equal number or share of military cuts. So our concern here is not just to avoid the bad effects on the economy of pulling demand out of the economy too quickly, but also to make sure that from a healthcare point of view, the cure is not worse than the disease. We don't want to see higher healthcare cuts and higher cuts in domestic spending overall as a result of avoiding the fiscal cliff. So that means that we have to make sure that healthcare is protected in the months ahead. Let me say a few words about how we see this going down. Sort of a three-step process. The first step is that Congress has to agree to an overall level of budget cuts, including specific levels of cuts in health spending. That could happen in the lame duck session between Thanksgiving and Christmas, but I'm guessing that since, as a friend of mine said, Congress can't organize a one-car parade over a period of, a 4-week period, I'm just guessing that it's going to take them into January, and again, that's why I think we'll probably go over the edge of the cliff for whatever that's worth. The key question here for healthcare advocates is, what is that target number? What's the number assigned to healthcare savings? The bigger that number, the harder it is to come up with good policies to fill that number and protect beneficiaries. The second aspect of how this sort of unfolds is that there has to be an enforcement mechanism, sort of like Sequester 2, which is what happens if the committees who are assigned to come up with legislation to implement those cuts don't come up with that legislation. So there has to be an enforcement mechanism for this agreement. And that enforcement mechanism, the key question from a healthcare point of view is what's included. Remember all the things I said that were exempt from the sequester. We would want to see all of those things exempt from any future enforcement mechanism. So all of the tax credits in the ACA, cuts to Medicaid, Medicare benefits, we would want to make sure that all of those things are off the table. And then the third element of the sort of how we get out of the fiscal cliff is that the committees of jurisdiction, which in our case means the Senate Finance Committee and the House Committees on Ways and Means and Energy and Commerce, have to take whatever number they were assigned in this deal and come up with health policies that will save that amount of money. And here, the key goal for consumers is to make sure that we have policies that don't shift costs onto beneficiaries, that don't undermine access. I think that there's a critically important point here, which is that the cost shift onto Medicaid, any cost shift onto Medicaid from the federal government to state governments is going to undermine our ability to persuade state governments to take up the Medicare expansion. So courtesy of the Supreme Court, the Medicare expansion is effectively a state option, even though technically it's still not. And governors' biggest fear and state legislators' biggest fear is that the federal government will pull the rug out from under them and will not honor their commitments to funding their share of the Medicaid expansion. So anything that the federal government does to feed into those fears is going to make our job of getting states to take up the Medicaid expansion much, much harder. So 4-point consumer agenda. right now, starting today, and going through until we have a number for what that healthcare cut number will look like. Our job is to make that number as small as possible. Second part, keep Medicaid, CHIP, ACA, Medicare benefits out of any enforcement mechanism. 3, no cost shifting onto the Medicaid program, period. And 4 is to make sure that any policies that do get developed actually target waste and low-value spending in our healthcare system, and that we protect benefits and we protect beneficiaries going forward. So why don't I stop there and open it up for questions.
Great. Thank you so much for that, Michael. We'll give people a second to submit any Fiscal Cliff questions. If you do have any questions, please submit them in the questions box on the lower right-hand corner. If I don't have any, we will continue on with our presentation. All right, it doesn't look like we're getting any questions. It must have been a great presentation, Michael. You answered all their questions about the Fiscal Cliff.
Or an eye glazer.
No, I don't think so. All right, thank you so much for your input. It was really helpful, and we're going to continue on with our presentation. Kathleen Gemeiner is now going to speak on insurance market reform.
Hi, everyone. Well, the most significant market reform created by the Affordable Care Act is its prohibition against the exclusion from coverage and discrimination in pricing due to a pre-existing medical condition. And for employers, and primarily small employers, a very sick employee or family member has resulted in skyrocketing premiums. And we're aware of situations where employers have even asked employees to get off of their group policy in order to make premiums affordable for their co-workers. And in the individual market, the situation has been worse, with tens of thousands of Ohioans unable to purchase insurance or being charged a rate that is not affordable because of a pre-existing medical condition. And often these conditions were manageable, not even life-threatening conditions. But following the election, we now have both a White House and a Senate that will oppose any further attempts to repeal the Affordable Care Act, and the protection against discrimination based on a pre-existing condition is protected for the foreseeable future. And while some parts of the Affordable Care Act still face threats through the budget process and the Fiscal Cliff resolution, the prohibition against discrimination on pre-existing conditions is less vulnerable. But what people have to understand is that the ACA does allow a rate differentiation based on age, and that rate differentiation is 3-to-1. That means a person 60 years old in the exchange can be charged 3 times what a 20-year-old is charged. But keep in mind that right now in Ohio, based on pre-existing conditions, rate differentiation is far greater than 3-to-1. As a result of the better protected status that the Affordable Care Act now has, insurance companies will continue to offer coverage to a family's young adult members up to the age of 26. And most importantly, we now know that the exchange will go forward, whether a federal, state, a state exchange, or a partnership exchange. Ohio has a number of decisions to make. First, will it do a state-based exchange? For now, the answer to that question is almost certainly not this year. Second, will Ohio do a partnership exchange? As of this past Friday, states have now been given until February 15th to make that decision. However, the previous deadline for deciding whether Ohio will have a state-based exchange still holds, November the 16th. If Ohio does not submit an indication by this Friday to HHS that it will run a state-based exchange, then we can assume we will have either a total federally facilitated exchange or a partnership exchange. Second, open enrollment must begin on October 1st, 2013. Well, what does this mean for Ohio? If Ohio decides to do a partnership exchange, accepting what's called the plan management function, then Ohio must put out a request for bids from plans who will sell insurance in the exchange, determine which plans meet the requirements of the Affordable Care Act, select the plans, approve their rates, approve their benefits package, approve their marketing materials, all in time for them to start marketing by mid or late summer of 2013 so that open enrollment can begin on October 1st, 2013. Third, if Ohio decides to be a partnership exchange and accept the responsibility to do navigation, Ohio must select a navigator or navigators, establish rules for navigators, train them, or provide for their training, and make sure they are on the ground by at least midsummer to be helping people get ready for the October 1st open enrollment. This training will include pointing people to the exchange website, helping them learn how to read the site, compare plans, how to calculate their tax subsidy, and understand their obligations to report income changes that could impact the amount of their subsidy. And Ohio will also need to make sure there are navigators who can address the needs of businesses who want to enroll in the SHOP exchange, the Small Business Health Options Program. Now, we know that as a result of the election and the new, more protected status of the Affordable Care Act, that women can no longer be charged a higher premium than men. Health policies must cover minimum essential health benefits. There can be no annual or lifetime dollar limits. People cannot be dropped off insurance except in cases of fraud or failure to pay their premium. And it requires insurers to provide a summary of benefits to consumers. There are also, excuse me, same market regulations will apply in the exchange, both in the individual market and the small group market. And as a result of the new protected status of the ACA, we know there will be a continuing requirement for rate reviews. In Ohio, we review all rates, but the federal government will continue the requirement that rates over 10% be reviewed, and that there is transparency in those rate reviews. And finally, what we've come to call the 80-20 rule will be protected, and that means that insurers must spend at least 80% of the premium dollar on health claims and only 20% on administration and profits. I have already talked pretty much about the plan management, and I know that we are running short on time here, and so let me just say one quick thing, and that is that what Ohio still has left for pretty much for the federal government to do is to decide what the benefits are that are going to be in the plan. There is a requirement that states select one of 10 types of plans as their essential health benefit plan model or benchmark. Ohio didn't make that decision, and so it will be left to the feds. The federal default benchmark is the smallest, the largest of the small business plans, and in Ohio that is an Anthem Luminos PPO, and it looks like that's what Ohio will go with. What consumers can do to protect our position in the market is to attend Ohio Consumers for Health Coverage meetings. There are meetings in the Southwest, the Northeast, and in Central Ohio. You can follow us on Facebook or Twitter. We especially invite people to share their stories with us so that we can broadcast that throughout the state, and sign up for UCAN Ohio Speakers Bureau so we can get the word out to folks. Alyssa, I think we're ready for our next speaker. I believe that's Kathy Levine. Kathy will talk about the Medicaid expansion.
Hi, folks. This is Kathy Levine, Executive Director of UCAN Ohio, and I'm going to talk about the Medicaid expansion. One of the key strategies in the Affordable Care Act for expanding affordable coverage to uninsured people is through the expansion of Medicaid to all people under the age of 65 with incomes below 138% of the federal poverty level. And as you can see from the chart in the presentation, that's around $15,000 for one individual and $26,000 for a family of 3. Now, next, please. However, the Supreme Court, in its historic decision holding the Affordable Care Act constitutional, removed the penalty in the law for states who decide not to implement the implement the ACA Medicaid expansion. Therefore, some states consider the expansion optional. Ohio has taken the position, Governor Kasich's administration has taken the position that they are going to conduct a cost-benefit analysis, which they're doing now, and they're receiving public input. They will announce their decision in the context of the next biennial budget, which would be on or before February 4th, 2013, which is the day that the governor introduces his budget. After that, the legislature considers his budget and is supposed to finalize the next biennium's budget by June 30th of 2013. So that's the time frame through which the decision will be made. The first important signpost is whether the governor recommends expanding the Affordable Care Act in the budget that he files on or before February 4th, 2013. And the administration has said they'll make their announcement sometime on or before that date. Next slide, please. Now, it's important to understand what the Medicaid expansion will cost Ohio. In the years 2014 through 2016, if Ohio does the ACA's Medicaid expansion, the federal government will pay 100% of the cost for the new enrollees. That's 100% of the cost. Ohio is concerned about other costs that they're going to have, such as people who are already eligible for Medicaid but are enrolling now, and for those people, Ohio has to pay their regular match rate. But for the newly eligible, 0% for the first 3 years. Then between 2017 and 2019, the federal government's reimbursement goes down gradually, and the state picks up for 5%, 6%, and 7% until it levels out after 2020 at 10%. Next. While the state will eventually have to contribute a small portion of the Medicaid expansion cost, it's important to understand overall what this expansion means to Ohio and why it's the absolutely right thing for Ohio to do to expand Medicaid. First of all, it will create a giant injection into Ohio's economy. Because the federal government is paying the full amount and then most of the cost of the expansion, over the first 6 years, the estimate of federal dollars coming into the economy is at least $17 billion over 6 years. This will have a tremendous multiplier effect on the economy, creating jobs, creating economic activity, creating more tax and income tax and activity tax revenues for the state. The other thing it will do, of course, is to promote healthier Ohioans, people with chronic conditions getting regular health care in low-cost settings instead of showing up very sick and crowding our emergency rooms and our hospitals with uncompensated care that gets passed on to taxpayers to pay. Next, please. The consequences of not doing the Medicaid expansion will be grave for Ohio. Without the expansion, we will have at least 800,000 Ohioans who will remain uninsured without the ability to pay for health insurance and health care. Now, one of the things that the state is considering is to do the expansion only up to 100% of the federal poverty level instead of 138%. We do not know yet whether the federal government will allow Ohio to do that, because the law is pretty clear that the expansion and the federal funding for the expansion is for an expansion up to 138% of federal poverty level. We're hoping the federal government to answer that question in the next couple of months. But even if the federal government decides to allow Ohio to expand only to 100%, we believe this would be a great mistake, because the people at 100% and above are able to go to the exchange and get tax subsidies. However, they'll have to pay premiums of up to 2% of their income and will incur modest cost sharing. But for people living at or close to the poverty level, even modest cost sharing will drive people out of the expansion. So what you can do is to advocate for the full Medicaid expansion by joining our coalition and local coalition activities. Let us know where you live and we'll plug you in. Sign on to the organizational sign-on letter, which is being circulated, and attend an in-person postcard writing event that the National Association of Social Workers of Ohio is sponsoring. Write a letter to the editor. Speak up now. Thank you so much. And I'm going to turn it over now to, sorry.
We're going to turn it over to Nita now. She's going to speak on how the election and the Affordable Care Act affects communities of color.
Thank you.
So, hello everyone. I'm going to spend some time talking a little bit about how the Affordable Care Act addresses health disparities. And just so that we're all on the same playing field, I'm going to give you just a quick definition of health disparities, what I mean when I say that. Health disparities is the unequal burden of chronic diseases, health status, mortality on different populations. For instance, many of you have heard terms like, or statements like, African Americans experience higher rates of hypertension or diabetes. Latinos may experience higher rates of cancer. Those are what we consider health disparities. So the new law, the Affordable Care Act, has several provisions that will create different resources to help reduce health disparities. So I'm going to talk about a few of them, but I'm only going to focus on two for the time that I have. So when we look at the Affordable Care Act, some of the different provisions that will create resources in those communities that are hardest hit by health disparities include the navigation program, Medicaid expansion, both of which we've talked a little bit about on this call, data collection. The new law requires that we collect data, or that public institutions collect data by race and ethnicity, which will allow for better information on where higher rates of diseases are happening, and will also help us to be able to plan for and develop population-specific health strategies. Community health workers. There's a provision in the law to expand community health workers, and there's also a provision in the law to expand community health centers, both of which would add resources in communities of color. As many of you know, community health centers are one of the biggest places that many communities use to receive health care services. So many of the communities that are hardest hit by health disparities, many of our urban communities and oftentimes rural communities, community health centers are their primary source of care. And likewise, community health workers are often used by public health centers, schools, a number of organizations that work in communities of color. So I want to focus my time on talking a little bit more about the Navigator program and the expansion of community health workers. So why is the Navigator program so important? This program will provide funding for face-to-face enrollment. When we think about communities of color and some of those rural communities where oftentimes there's a lack of health resources, a lack of information, may even be a lack of technology, information skills and infrastructure, this will be really important. Many times when we have new programs that are rolled out, communities of color and rural communities don't always get that information because they often need different kinds of strategies for outreach and education. So sometimes it is not just enough to have, for instance, an 800 line or an online process, because many from these communities may not use these sources. So navigators will be essential, and particularly navigators that come from communities that have the knowledge of the community, are comfortable with going out and knocking on doors, and have trust of the community. They're going to be essential to overcoming some of the cultural and linguistic barriers. They're also going to be essential to continuity of care. As we think about enrolling the many of those out there that are now currently uninsured in insurance, enrolling them in insurance and giving them an insurance card may not necessarily mean that they will get linked to primary care and stay connected with primary care. So if we can create a system where our navigators are also those that are both trusted by the community but also have some knowledge of health resources in the community and some knowledge of health care, that will be very helpful in having a system that provides more continuity of care, that enrolls people as well as links them to care. Next slide, please. Thank you. So what's happening right now with navigators? As mentioned earlier on the call, Ohio has not yet moved forward with creating an exchange, nor have they moved forward with creating a navigator program. Whether we have a federally facilitated exchange or a state-based exchange, we will still need navigators. So some of the decisions that have to be made, of course, are whether we will have a state or federal navigator program. We will need to begin to understand who our navigators are going to be. Right now, there's not a plan in place, so we have to look to those community-based programs that are already there and some of those statewide programs that have the capacity to be navigators, and begin to think about who makes sense to be navigators. How will we make sure that these navigators come from communities who are hardest hit by disparities? Will the state apply for funding? There were grants released in July for assisters, and these assisters were to be similar to navigators, that if this money was to kind of bridge the gap for states to begin to look at their navigation program and begin to put a process in place. Again, Ohio did not apply for that funding. There will be future funding in addition for navigators, as well as the funding that will come from the creation of the exchange for navigators. So we want to find out whether our state, or we want to keep on top of whether our state does actually apply for these funds. There needs to be a planning process for establishing a navigator program. As I mentioned before, so far we have not done that. We want to make sure that we include in this planning process those large programs that have some capacity to provide navigation services, as well as some of those small community-based programs that are already providing similar type services in their communities. Next slide, please. So what can consumers do? In terms of navigators, We at UCAN Ohio are working hard to create this central conversation so that we can begin to have a planning process around navigators in Ohio. Consumers can participate. We are having a call on Wednesday to discuss this issue. We will also have sign-on letters. We will be talking to our legislators about creating this planning process. You can join us in asking our legislators to make sure that we have a robust navigation system in Ohio that meets the needs of all Ohioans, particularly those communities of color and language communities. And before I close, the other issue that I wanted to talk about real briefly is just community health workers. Community health workers are another way of expanding the workforce and building the capacity of primary care practices to, again, reach into those communities of color, those language communities, those rural communities, and disability communities where we may need particular strategies for outreaching, enrolling, and linking to care. And community health workers are a strong workforce to help this happen. They can help, by providing linkage to primary care, but they're also used in a number of different ways. They provide chronic disease management services. And we should work hard to ensure their inclusion in the primary care workforce. So again, as we begin to move forward with educating our legislators and encouraging them to use community health workers, we can also use your help. We will be doing sign-on letters. We are in the process of identifying where community health workers are used across the state and bringing them into the conversation to help systems figure out how to expand their use.
Okay, great. Thanks so much, Anita, for all that information on how the election will affect communities of color and how we can move forward with the Affordable Care Act. Next, we're going to be having a presentation continuing with Kathy Levine, who's going to talk about delivery reform. Just a reminder, if you have any questions, please submit them in the lower right-hand corner in the questions box. Kathy, take it away.
One of the areas that's getting very little attention in the public about healthcare reform is how are we going to improve the care that people get and lower healthcare costs. The impetus for healthcare reform was largely that we're spending too much on money. So as this slide shows, Ohio is spending way too much per person on healthcare, and healthcare spending is not resulting in higher quality. In fact, a lot of the spending goes for care that's harmful for patients. So Ohio is very active in initiatives to improve system performance. And these initiatives, next slide please, these initiatives can really transform healthcare and the health of Ohioans, particularly those with chronic health conditions, those people with diseases and other serious ongoing health needs, to have much better care. So the Ohio Office of Health Transformation is working toward Medicaid health homes, which is an ACA initiative which gives the state extra money to provide care for people with chronic health conditions, and the state is focusing on Medicaid health homes now for people with serious mental illness by integrating the care between physical and mental health care, and we're hoping they'll expand health homes to other people with chronic conditions who would improve their health outcomes and lower health care costs if they had better health care coordination. The state is working aggressively on getting a demonstration up for people who are both enrolled in both Medicare and Medicaid to put them in what they're calling integrated delivery system plans, which are managed care plans, and UCAN Ohio is coordinating advocates for seniors and people with disabilities, patient-centered medical homes, and a proposal for a state innovation model to improve funding for patient-centered medical homes and other innovations. Next. So an important opportunity for better care is the promotion of ongoing primary care for people, particularly people with health conditions. We're spending way too much in Ohio on treating the results of people with chronic conditions like diabetes and hypertension and lung disease and so forth, who don't get good primary care. So the models that Ohio is promoting are models that increase patient-centered care, not provider-centered care, where the patient is in the middle of a care team. Care coordination across settings to reduce preventable hospitalizations and harm, and to reduce the need for hospitalization and nursing home care, and paying providers to improve health outcomes rather than paying them for volume of care delivered. Next, please. Now, as I said, these new models of care provide great opportunities for better care for patients with chronic conditions and patients who are duly eligible for Medicare and Medicaid, but there are great dangers for consumers. Without a strong consumer voice, consumer priorities may not be heard in the design of the new systems. Systems will continue to be unresponsive to the needs of individual patients without a strong consumer voice. Saving money may lead to a loss of needed services and the services and providers that consumers rely on the most. So next, please. What can consumers do? It's very important that we have a robust consumer voice in a number of initiatives going on in Ohio. One is to get involved with Ohio's ICVS consumer advocates, which UCAN Ohio is coordinating to build a strong consumer voice in the new demonstration for people who are eligible for Medicaid and Medicare. Get involved in the Ohio Patient-Centered Primary Care Collaborative, which is working to develop a patient-centered medical home model throughout all Ohio for all patients. The consumer voice is desperately needed in that collaborative. So I think I'll wrap it up there so we'll have time for questions. Thank you.
All right, great. Thanks so much for that input, Kathy. Today we'll move on to any questions people have. I have unmuted Kathy and Kathleen, so please, both of you, feel free to answer the question that's appropriate. The first question we have is, how does Obamacare or the Affordable Care Act influence the employees who work part-time or multiple part-time jobs or jobs without insurance benefits?
I'll jump in there. This is Kathleen. I think that the Affordable Care Act really helps these workers the most of any of them, because they will have the opportunity to go into the individual exchange if they're not offered health insurance on the job. And in the individual exchange, they will be able to get a subsidy that's matched to their income. So this is the group of people who I think really has a tremendous amount to gain. If their income falls below 138% of poverty, if Ohio accepts the Medicaid expansion, then they will actually be eligible for Medicaid. And in that case, we'll have no amount of money that they have to pay toward a premium or no deductible.
Okay, great. Another question we have is, how will the ACA impact low-income children currently covered by free insurance, not Medicaid in Ohio?
I'm not sure I understand that question when they say children covered by free insurance, not Medicaid. I don't know what that means.
I'm wondering if the caller, if the writer means employer-based insurance. We expect that children who have employer-based insurance will continue to receive their employer-based insurance. but the free health care that exists is Medicaid, whether it's Medicaid or the federal CHIP program. It's all Medicaid in Ohio, and that coverage will continue.
Okay. We have a question specifically about dental and Medicaid. Will there be any implications on dental Medicaid coverage, and is that part of the ACA?
Well, I have two answers to that question. First of all, the Medicaid expansion will provide, we hope, the same benefit package that people on Medicaid are getting now, but that question remains to be seen. That the state could create a different benefit package for adults who are newly eligible for Medicaid, and that could leave out dental care. So the answer to that is up in the air, because so we're going to have to advocate to make sure that dental benefits remain in the expanded Medicaid program. Secondly, the Ohio legislature may go after the dental benefit that's now in Medicaid for all adults currently on Medicaid as part of reducing health care spending. This happens frequently during the budget process, and in the past, advocates and supporters of dental coverage have fought back successfully. We may have to wage that battle and win it again.
Okay. What is expected to happen with federally qualified health centers? Will there be a huge increase or decrease in their patient populations, and how will they be affected?
Well, that's a great question. First of all, the ACA practically creates a lot of funding for federally qualified health centers that basically double their capacity to see patients. We're hoping that a lot of people who now have Medicaid coverage will go to the federally qualified health centers because they live in provider shortage areas and the FQHCs provide very good ongoing care. So the federally qualified health centers will be able to grow because they have more patients with, who have a payment source. But we should keep in mind that the implementation of the Affordable Care Act will not wipe out the uninsured overnight. It's going to take years and years for us to get unenrolled, low-income people into Medicaid. It may take several years, and there will be people who still fall through the cracks, including immigrants who will not be eligible for Medicaid even with the expansion. So we will still need providers such as federally qualified health centers treating people who have an inability to pay for health care and don't have coverage. And there will be people who get coverage through the exchange who may not be able to pay all their cost sharing and will need help from the federally qualified health centers.
Okay, thanks, Kathy. Now a question about the exchange. Can you do a comparison of the federal exchange, the state exchange, and the partnership exchange, and explain which one we should prefer and why?
Well, yeah, this is Kathleen, and I would say that the federal exchange simply means that the federal government will do all of the things that Ohio otherwise would do. That means there will be the web portal to which people will go and review the available plans and pick their plan. There will be navigators provided through the federal government, Ohioans, but through request for proposals issued by the federal government. All the plan selection will be done by the federal government. If Ohio does the exchange, all these functions will be done by Ohio. So the difference there is whether HHS does it or whether the state of Ohio's Department of Insurance or an exchange itself, preferably an independent body, would do it. In a partnership exchange, the federal government will do all of the, you might say, mechanical work of the exchange, but the plan selection or the navigator selection and training and supervision could be done by the state government. As far as preferring which is better, the one that is best is the one that works best for Ohioans, and it could be done very well by the federal government. It could also be done very well by the an Ohio exchange if we had one, or the Department of Insurance if it does the hybrid exchange. But the department's going to have to be committed to the Affordable Care Act being carried out in a way that works well for all Ohioans. And so that's really the question. Who is most committed to making this work and will do the best job for Ohioans? I really can't express at this point a preference. Certainly our preference in the beginning was that it be a state exchange. We felt that would provide the greatest amount of autonomy in the state, and over time I still think a state exchange would be the best way to go. But in terms of the best way to go at this moment in time, facing an October 1st, 2013 open enrollment date, you know, I think we have to say who can do it quickest, most efficiently, and has the greatest investment in making sure that it works right for consumers.
Thank you, Kathleen. Next, can you tell us about some upcoming deadlines or next implementation dates that we should all be aware of?
Well, on the market side, just recently, in late September, the summary of benefits requirement became effective. So now whenever someone enrolls or has open enrollment, they should, at their workplace or through their own individual policy, they should be given a summary of benefits which explains in very clear language what those benefits mean, has some examples of how they would be applied. Then the next deadline, of course, the big one, is November 16th, when the state will have to inform the federal government whether it's going to go with a state exchange or a federal exchange. If the state decides to not do a state exchange, and therefore there's an assumption that it's a federal exchange, the state still has the opportunity to decide sometime between now and February 15th whether it wants to assume some responsibility for plan management and or navigation, which would be a partnership exchange. So the other deadlines are there's a deadline this Thursday, the 15th, that the state could apply for an exchange grant if it decides it wants to go ahead and do a partnership exchange. We have no indication that the state of Ohio plans to submit such a grant, but we could be surprised. And then the next opportunity to apply for such a grant would be on February 15th, which coincides with the partnership deadline.
And that would enable states, Kathleen, Ohio to get money to set up an assister program, right?
Correct. If they would go ahead and do that, they could get money that would enable them. And that's, if they decide to do a partnership exchange, they could get money just as other states, such as the state of Arkansas recently, has gotten millions of dollars to hire people who will go out into the four corners of the state and educate people about the coming of the exchange and the October 1st, 2013 open enrollment date.
Thank you. Our next question is about whether Ohio can afford the Medicaid expansion. What would be a response to people who say that Ohio can't afford it?
Ohio cannot afford not to do the Medicaid expansion. Currently, $1,000 of a family health premium goes to paying for providers for giving uncompensated care. That's been documented, that the health care costs of people who pay for health care are being used very inefficiently to make up for uncompensated care. We have too many sick people in public programs who didn't have to be that sick if they had gotten continuous primary care. So we need to be investing now in a healthier society, a healthier workforce by expanding Medicaid. We're not going to attract jobs to Ohio if we don't do the Medicaid expansion. Secondly, the Medicaid expansion, as I said before, is bringing in billions of dollars in federal money, which is going to be a booster shot to Ohio's economy, boosting state revenues. The state revenues that will come from expanded jobs and from expanded economic activity due to the Medicaid expansion will more than provide extra revenues to the state that they need to contribute to the Medicaid expansion. And there are some analyses that have been done in other states, and analysis is being done now in Ohio that will be available in the next couple of months to show what an economic plus it is for Ohio to do the expansion. So not doing the expansion would be a blow to our economy and a blow to the health of Ohioans.
Great. Thank you so much, Kathy.
Thank you.
The next question is about where are there opportunities to build coalitions to push the issues of building a navigator program that works for Ohio, setting up an exchange, and expanding Medicaid?
Maybe Nita wants to jump in on that.
I think
on the navigator piece. Is she unmuted?
Nita's not available, but we can talk about in terms of the navigator program what we've been doing and what Nita's been doing. Nita, folks, has a really bad cold, and so I think she dropped off. We've been talking to organizations around the state to find out who's interested in participating in a navigator program. If Ohio decides to let the federal government set up the navigator program, they're going to be required to have a contract with community-based organizations. But rather than having the federal government decide who to contract with, we think it makes more sense for there to be a conversation among people who want to be involved in a navigator program so that we could have a proposal ready that includes all of the populations that need navigators. So we are, in the absence of any kind of government-led process, we're starting to convene a process, and we'd love other people to join us in that process.
And Kathy, I should just add that if there are people, organizations who think that they will become navigators or may want to become navigators or contract with a major navigator, they should get in touch with Nita to get more information about how to get on the conference call that's planned for this coming Wednesday. And Nita can be reached at ncarter@ucanohio.org.
Or just call the UCAN Ohio office and we'll put you in touch with her.
All right, at this time, I would like to thank everyone, especially our presenters, Michael Miller, Kathleen Gemeiner, Nita Carter, and Kathy Levine. I would also like to take this time to thank everyone who attended this webinar and submitted these great questions that we just got done answering. We really hope that this presentation leaves you feeling proud of how far we've come, but also empowered to continue the implementation work that is so important. If you have any unanswered questions, log on to our website at www.ucanohio.org and submit a question in our question and answer forum. To stay up to date on recent developments nationally and in Ohio, like us on Facebook, follow us on Twitter, or sign up for our email updates by emailing rdillo@ucanohio.org. We will be sending up a follow-up email in the coming days with this PowerPoint, a recording of the webinar, and links to other helpful information. This concludes our presentation. Feel free to disconnect